All right, very good. Well, thank you all for joining me tonight. It's really a pleasure to speak with you about some common foot issues that we see in the office. We're going to go over basically from toes up to the ankle in terms of what we see on a daily basis and some options that we have for you, and maybe be able to answer some questions that you've been thinking about for quite some time. So I broke this down into sections of the foot. We think of the forefoot as extending from basically the toes to the metatarsal level, and then the midfoot as well as the hindfoot, thinking about your heel and the area underneath your ankle. And then, of course, the ankle joint as well. And for me, this is kind of like a roadmap of where things are going to go. My favorite roadmap or area is out west in Montana. And so I have a little roadmap here of Yellowstone National Park. I had the pleasure of fly fishing my way through the park a couple of years ago, and it always brings back really good memories. So in the forefoot, one of the big things that we see are bunion deformities, and very, very common. A lot of people are worried that, you know, the shoes that they wore or have worn in the past are causing the problem. Really, this is an inherited issue that we see this big bump on at the base of the big toe joint here. And it came from mom, dad, grandma, grandpa. It's not something that you develop over time. It does get worse with time in certain situations, and it's certainly exacerbated by shoes that don't have enough room. So obviously, as that bump protrudes more and more, a narrow shoe will really, really irritate it, but it's probably not what caused it. A lot of folks come in and they ask me, you know, is this, you know, I heard this is a bone growth or a spur or a tumor, just something that we shaved down. And it's actually not. It's actually, you know, an irregular deformity of the architecture of the bone. And so you can see that the first metatarsal here is straight behind the big toe joint here, but it's angled out toward the midline of your body away from the others. And this creates that bump there. Like I said, it can be progressive over time. Usually, our first conservative treatment option is just simply wearing a wider toe box shoe. So not necessarily going up a size or a half size in your shoes, but buying a wide size. Sometimes that requires going double, triple, quadruple wide in some cases, but that can take pressure off of the bunion. Orthotic inserts can be helpful as well, because we see bunions oftentimes with flat feet or even high arched feet, and oftentimes supporting the arch can take the pressure off of the bump as well. It doesn't take away the bump, but if it can reduce your pain, that's a good option. From a surgical perspective, you know, we think about these with bunions that have failed conservative treatment and patients that have had, you know, years of deformity that it's now getting into affecting their quality of life, pain on a day-to-day basis with each step. We choose our surgical procedures, first of all, by severity of the deformity. You know, how big is the bunion? How great is the angle between the first and second metatarsals that we're trying to reduce? But we also take a lot of consideration into the age of the patient, the activity level of the patient, kind of goals, aspirations, things that they want to do with their life. And a lot of people, you know, with any kind of foot and ankle surgery, they're always wondering, you know, how long am I going to be off of my foot? And that is actually dictated by the type of procedure we choose. So here's a couple examples. There's over 100 different surgical procedures that have been listed in the literature over the years for bunion deformities. And this is just three of the common procedures that I perform. So first one is a first metatarsal osteotomy. That means cutting and shifting the head of the bone over towards the second metatarsal. You can see the screws in place on the left picture there. This is usually for a mild to moderate bunion. This procedure is nice because it actually allows immediate and early weight bearing. So most of my patients for this procedure are in a boot for about 6 weeks, but they're allowed to bear full weight on it immediately from the operating room. And that provides a nice way for patients to get back to their day-to-day without having to be on crutches or to be in a cast or a splint for a long period of time. The second procedure I have listed here is a lapidus bunionectomy. And this actually goes way back to the first metatarsal cuneiform joint back here, where you see this plate and screw construct on the right. And so it goes all the way back to the base of the first metatarsal to shift the entire bone over to create that parallel angle between the first and the second metatarsals. It's indicated for more severe bunion deformities, but it's also indicated with instability at the midfoot. So sometimes we see that there's just significantly more motion than we would expect at that joint. And that can be an indication that even if we did a bunion procedure like you see on the left-hand side, that over time we might see recurrence of that bunion deformity. And so we certainly look to the lapidus bunionectomy to try and prevent recurrence and to try to help, especially younger patients that may have a bunion earlier in life, prevent that from worsening over time. The third procedure I have listed here, I don't have a picture of, we're going to talk about that later. It's called the first metatarsal phalangeal joint fusion, and that's where we actually fuse the great toe joint. So we remove the motion there, but we're basically definitively making sure that both that angle doesn't increase and the big toe doesn't continue to drift over into the second toe. I like to use this procedure on patients that may already have arthritic changes to the joint, and especially older patients that are also looking for a faster recovery and kind of some insurance policy here that we're not going to see the toe drift. This is especially important for patients where maybe the bump doesn't bother them as much, but the toe drifting over into the second toe can be a problem. The second thing we're going to talk about is called Hallux, limitus, or rigidus. And this is literally what it sounds like. It's a stiff great toe joint. You can see in the picture here on the right, this is what we think of as end stage Hallux rigidus, where there's been near complete destruction of that big toe joint. A lot of patients will come in and think they have a bunion, but they'll say that the bump is on the top rather than on the side of their great toe joint. It can be very, very painful with push off, whether that's walking or running, but when you go to take the step and push off of the big toe joint, that's usually when it hurts patients the most. Conservative treatment usually first off consists of stiff-soled shoes to prevent unnecessary motion at that painful joint, and orthotic inserts to try to help alleviate the excessive motion there. We use what's called a Morton's extension modification to the orthotic to prevent the jamming of the joint on the top, which is what causes patients a lot of pain. We can use anti-inflammatory medications as well as injections in the joint on an infrequent basis to alleviate flares of pain, of course. From a surgical perspective, we split this into joint sparing versus joint destructive procedures. So there are procedures that we can do to clean up the joint called a chylectomy, try to remove any bone spurs around the joint, try to alleviate any areas of pressure, pain, and decompress the joint to allow for a little bit more space. But when the arthritis becomes more severe, we think more toward that first metatarsal phalangeal joint arthrodesis that we talked about on the slide before. And here's a photo of that here. So this is actually the same patient. She elected to have the procedure done on both feet. I never do surgery on both feet at the same time. It usually makes for a very difficult recovery. And I always kind of make the joke, you got to have a leg to stand on, at least a good one. And so these were done about 12 weeks apart, and she went on to do quite well. But you can see here that we use a plate and screw construct across the first metatarsal phalangeal joint, across that big toe joint. And basically what we're doing is we're removing the motion from that joint, but we're holding the position and alignment in a corrected position. And without the painful arthritis there, we now just have a rigid lever arm to push off of and gait that no longer causes pain, and it becomes a great option for those patients. Hammer toes are a big issue in the forefoot as well. We see quite a few of them. We're mostly talking about the lesser toes, so toes 2 through 5. It's often associated with a flat foot or a high arch foot component, and very, very often is a component of bunion deformity. We will many times have patients that perhaps have mild to moderate bunions, but come in because the second or third toe is beginning to contract in a hammer toe deformity. And their main complaint is the hammer toe, but it's very difficult to address one and not the other, because as you can see here in the first x-ray on the left, you can see that the big toe is now underlapping the second toe, and that causes an issue. So it's very commonly associated with bunions as well. These hammer toe contractures, basically, you can see on the picture on the right here as that the toes kind of bent in sort of an upside down V-shaped formation. They can be rigid or flexible, meaning that you can easily straighten them out in your hands, or not. And so that helps to dictate if we're going to head to the operating room to correct the hammer toe. It helps to dictate what kind of procedure we choose. From a conservative perspective, orthotic inserts can be helpful for the same reasons that we talked about with bunions. But here, an extra depth shoe can make a big difference. So especially if the pain is on the top of the knuckle at that contracture, that rigid deformity of the toe, just giving the toe a little extra space on top can be a big help. Crest pads and toe caps can be helpful as well. These are padded devices that either go underneath all 4 toes or individually over each toe to just either cushion or offload those areas. When conservative treatment measures fail, we look to surgical procedures that are either soft tissue in nature for flexible hammer toes or rigid, meaning that we may perform an arthroplasty, excising a joint or even fusing that joint. In these photos here, there are some other procedures done back further in the midfoot here, but you can see on these 3 hammer toe corrections. The first on the left is a traditional hammer toe correction where we used a pin to fixate. And then on the X-ray on the right here, we have a pin in the 3rd toe and a hammer toe implant in the 2nd toe here. And so there is some stigma around hammer toe procedures where people have known someone that used a pin. They didn't like seeing the pin stick out of their toe. So there are some options in cases of hammer toes where we're able to utilize new technology with hammer toe implants to prevent having a pin. Sometimes a pin is unavoidable, but it makes for a very good construct to keep the toe nice and straight while it's healing. The last thing we're going to talk about in the forefoot, which is quite common to see, is called Morton's neuroma. This is usually pain in the ball of the foot heading into the toes. That's usually tingling, burning, numb in nature. It may be progressively more numb the longer that you're on your foot. A lot of patients will describe it as a sensation of stepping on a rock or a pebble or having something stuck in their shoe. Exacerbated with long periods of weight bearing. So if you're on your feet for a long time or wearing high-heeled shoes, sometimes it's a particular exercise at the gym. My mom recently had neuroma surgery. She is an exercise instructor, and she spent a lot of time up on her tiptoes, especially on the arc trainer and the elliptical machine. And this really, really irritated her neuroma just being on the balls of her feet most of the time. It's actually an inflammation and a scarring of a sensory nerve. And you can see that in the picture here from the Mayo Clinic on the right. You can see how the other nerves along the interspaces between each toe are nice and thin there, but the neuroma that's pointed out is quite thick. And so what happens is that the nerve gets irritated between the bones, and this progression leads to a bigger, more inflamed nerve that begins to scar over time. The more it's inflamed and the longer it's inflamed. And unfortunately, the problem continues to exacerbate itself because now we have an even bigger nerve going through the same small spot that it was originally irritated in. The best way I've found to diagnose this is really with musculoskeletal ultrasound. These are still quite small, usually less than a centimeter. And sometimes with an MRI, we pick them up, but we only get small slices of the neuroma. And so I find that an ultrasound can be really helpful. From a conservative perspective, a lot of patients will do quite well with offloading these, so trying to take pressure away from the area. And usually I'll use an orthotic insert, so an arch support in your shoe that also contains what's called a metatarsal pad, and this reduces pressure to the entire ball of the foot. And oftentimes just simply taking the pressure away from this will allow the neuroma to calm down. Oftentimes we'll use a corticosteroid injection in combination with this for the same reason, to allow the area to calm down. When we fail conservative treatment, the procedure of choice is called a neurectomy. We'll basically remove that section of inflamed nerve. I often utilize the expression, this usually looks like a small chicken cutlet, especially when wearing surgical telescopes in the operating room, removing it. I let every patient know with neuroma surgery that the goal of the procedure is to take a painful foot and turn that area into some numbness. So we're always trading pain for numbness in the situation. This nerve that we remove is purely sensory, so it's not going to have effect on the motor function of your foot or your toes. But a lot of patients will get to the point where if this is considerably painful, they're ready to consider trading pain for numbness. So moving a little further back into the midfoot, kind of usually in the metatarsal area, so extending toward the midfoot is stress fractures. We see an awful lot of these, and in my experience, this is seasonally related. So I always think of stress fractures at the end of the summer, especially for someone who's done quite a bit of walking, either barefoot or in flip-flops or sandals throughout the course of the warmer months. These are overuse injuries. And the second metatarsal in the foot is most common. But I always use the expression that this is kind of like an area where it's like if you take a pen or a pencil in your hand and you bend it to the point right before it breaks, oftentimes what happens is, you'll see the plastic deform. If it's a blue pen, you might see that blue plastic turns white in that area. But also, we've now kind of interrupted the structural integrity there. So the next time that you go to do that, it might quickly snap. And that's the same issue with the bone. We're actually seeing the outer shell or the cortex of the bone become inflamed from the overuse. And the important thing is that if these go untreated, they can progress on to true fractures. So it's important, if this is becoming an issue for you, that you have it treated. Especially if the pain is new onset, so within the last week or so, x-rays may not be diagnostic. In this case, the x-ray on the left does show a very, very small bulge in the cortex there, inflammation in the cortex that indicated a stress fracture or stress reaction there. But that's not always the case. And so MRI is usually the best diagnostic imaging to fully diagnose these. Most all go on to do well with conservative treatment. It's very, very rare that we have to operate on a stress fracture unless it turns into a true fracture or becomes recalcitrant to conservative treatment. But the gold standard here is immobilization. And especially in the metatarsal level, I like to use a cam walker or a boot that goes above the ankle, simply because it fully immobilizes the foot and ankle. It reduces the pull of the tendons that are crossing the ankle into the foot across the fracture site and just allows the whole area to shut down. Usually immobilization is 4 to 6 weeks. And oftentimes after that 4-week mark, patients are feeling much better to the point where we can progress toward a shoe or an insert in the shoe to provide that immobilization for the last few weeks. On the right side of this picture, you can see this same patient's MRI, where you can see where the second metatarsal is showing up white. White in this sequence is inflammation within the bone consistent with the stress fracture, stress reaction, whereas the other bones here are black. Moving further back into the midfoot, we look at the navicular-cuneiform joints and the tarsometatarsal joints. I don't know if you can see my mouse here, but pointing to these areas. And this is a very common area for patients to develop arthritis in the midfoot. I like to think of this as developing arthritis due to it being at the apex of the arch. So it's kind of the top of the arch that's taking all the pressure. And it often affects multiple joints. These very small joints have very, very low motion, but they all coordinate that little motion together to form significant movements so that you can rotate your foot in different directions. Usually we see quite a bit of spurring on top of the foot. We call that dorsal spurring, and it can irritate the nerves, especially when shoes are tied too tightly or the laces are rubbing over those areas. And if you look down at the top of your foot, you'll notice there's just not a lot of soft tissue between the skin and the bone there. And so the nerves are relatively superficial. They're running very close to the skin. And if you have a shoe that's pushing down, squeezing the skin on top of those bone spurs on top, it can very often irritate the nerves. And that's often what brings patients in first. This can be degenerative, meaning that it's wear and tear arthritis, just like a lot of hip and knee arthritis, or it can be post-traumatic in nature. It may be due to a previous injury or fracture that you sustained earlier in life, but it's quite common. Conservatively, we treat this often with stiff-soled shoes, so trying to reduce the motion across those arthritic joints. A rocker bottom shoe can be very, very helpful here too, because the shoe's doing some work in terms of rolling off in gait rather than trying to flex through the midfoot to push off. And orthotic inserts can be helpful as well to support that apex or that arch to prevent that unnecessary motion too. From a surgical perspective, we usually perform fusions of these joints when patients fail conservative treatment that might consist of the above plus anti-inflammatories and injections and these things. We base the level of fusion based off of the advanced imaging, usually CT or MRI, that gives us the best indication of all the joints affected by the arthritis and the severity of that arthritis. Moving further back into the hind foot, so thinking about the area underneath the ankle, kind of in the heel and the area in front of the mid or behind the midfoot there. The first thing that comes to mind for me is a flat foot that develops what we call posterior tibial tendon dysfunction. And this is pain that runs along the inside of the ankle, often down to the insertion point of the tendon at the midfoot on the navicular. It's often due to a flat foot component. We know that we have more flat-footed folks out there than we do high arched, and oftentimes patients don't have early treatment, so they're not utilizing inserts or shoes or bracing as kids or young adults, and there are other times when they have an otherwise normal appearing foot in terms of flat foot versus high arch. And later in life, we see some of that arch collapse. But either way, whether it's inherited or adult acquired, it usually affects that posterior tibial tendon first. And we'll see patients coming in with medial ankle pain or pain on the inside of the ankle. It can be rigid or flexible. So there's times when that flat foot, I can take and shape that arch back in my hands, and other times where there's no budging in it at all. From a conservative perspective, the first thing we'll usually do is an ankle brace to reduce the pain and tenderness over the posterior tibial tendon. If patients respond to immobilization with bracing, then we often move on to orthotic inserts, often in these cases where there's significant deformity, custom molded. Sometimes custom molded bracing is even a really good option for patients who have significant flat foot deformity. And physical therapy and stretching can also be important because the calf muscle often gets very tight in these cases. From a surgical perspective, we base this off of the stage of posterior tibial tendon dysfunction, so stages 1 through 4. And we also think about this in terms of age and how much joint destruction has been done over time. So what I mean by that is I'm a car guy, I like cars, and so I try to use a lot of analogies that relate to those. And one of the things I think of is if the tires of your car are out of alignment, we'll see one side of that tire wear down to the belts and the other side looks relatively brand new. And that's the same for joints. So when joints are malpositioned, the cartilage might wear down to the bone on one side and look good on the other. The trouble is if we correct the position and alignment of the joints, but they're really not in good shape, there's not much cartilage left in these areas, we can develop kind of that bone-on-bone arthritis that you hear about in the hip and the knee and other joints, and that can create more pain. So there are times when a procedure like the one I have shown here in the x-ray on the right is necessary, where we fuse 2 or 3 of the joints in the rear foot to recreate the arch because there's been significant joint destruction. And there's other cases where the joints may look really good, and we can do procedures that involve maintaining the motion of those joints in order to correct them. Furthermore, we have patients with a cavovarus foot type, and I always think of cavovarus, it has cave in it, it's a high arched foot type. Oftentimes we'll see what's called peroneal tendinitis, which is pain along the tendons on the outside of the foot as a result of this. I always tell patients with a high arch to think about their footprint when they get out of the shower or out of the pool. It often will look very C-shaped. It'll look like there's only water or pressure along the heel, the outside of the foot, and maybe the ball of the foot. There's no real water on the floor from the arch because it's usually not touching the ground. And so I always talk to patients about how a high arch foot type often functions like a tripod with pressure under the heel and then behind the first and fifth toes. It often leads to some instability in the ankle, just the same way it's easier to roll your ankle in high heels. Sometimes higher arch patients will develop instability or frequent spraining of the ankle as well. Conservatively, we treat this with orthotic inserts or bracing. So we try to support that high arch and reduce the pressure to the areas that are taking more. When conservative treatment fails, surgical intervention can be a little bit more intricate with a high arch because there's often a midfoot and forefoot component. And for that reason, sometimes surgical procedures can range all the way from the hindfoot and the heel all the way toward the toes into the forefoot to completely restore and balance the alignment of the foot. And with this, we'll often include a peroneal tendon repair, which is often what the patients will present with first. I think the big one that most people talk about in the hindfoot is, of course, plantar fasciitis. And this is pain in the ligament that extends from the heel to the toes. It's the most common cause of heel pain. There was a study that came out a few years ago that even showed that weight gains as little as 5 pounds or more can lead to the onset of plantar fasciitis as well. It's caused by the lack or adequate support, meaning it could be walking barefoot, it could be wearing those sandals or flip-flops all summer long, and also a quite tight calf muscle and Achilles tendon. I think of the plantar fascial ligament as simply a continuation of the Achilles tendon along the bottom of the foot, since the Achilles tendon is inserting on the back of the heel and the plantar fascial ligament is originating from the bottom of the heel. And so we always treat plantar fasciitis conservatively first with stretching exercises that usually stretch the calf out as well. I have a lot of patients that say, hey, I'm stretching my calf, but what about my plantar fascia? And I always have to remind them we're working on both at the same time with those stretches. Orthotic inserts can be helpful here to increase the support that they were lacking to begin with. And then anti-inflammatory medications can be helpful as well. Conservatively, we can use something called shockwave therapy. I find this particularly helpful in patients that have a significantly thickened plantar fascial ligament on MRI. But most of these patients will improve with conservative treatment. It's very few patients that don't get better conservatively and require surgical intervention. Times when surgery is indicated is with recalcitrant cases, so cases where patients have recurrent plantar fasciitis, where this is their 3rd or 4th bout, or even sometimes where they've had pain that never fully resolved over several months or several years. And the other issue is sometimes patients will have been treated for quite a long time, but they've developed chronic tearing that's not improving with the conservative treatment. There are ways to ultrasonically debride the tendon or the ligament under ultrasound guidance. And then there are open and endoscopic releases that we can do through the scope to release a portion of the ligament to reduce the tension and then therefore take away the inflammation and allow the ligament to heal in a lengthened position. Moving on to the ankle, one of the most common things we see is pain along the back of the lower leg and the ankle along the Achilles tendon, and this is associated with Achilles tendinitis. Same thing as plantar fasciitis, they go hand in hand. This is caused by a tight calf muscle and lack of stretching usually. We see a lot of Achilles tendinitis with athletes, people that are at the gym a lot that are really working their leg muscles, but they are not stretching before or after or on a regular basis. And oftentimes the key to getting them better conservatively is quite a bit of stretching and physical therapy to increase the range of motion in the ankle, especially pulling the toes towards the nose. Heel lifts can be helpful as well. They're more used in the early stages when we're just trying to reduce the pain and inflammation. I tell people all the time that heel lifts can be a crutch that we don't want to depend on forever and ever, but they can be helpful. There is often times where you can see in this x-ray on the right where the Achilles tendinitis might be at the insertion of the calcaneus or the heel bone. And we see spurring develop here. And this is because the tendon's been tugging so hard on the bone that the spur will grow into the tendon, or the bone will grow into the tendon. And sometimes from a surgical perspective, we have to do that last procedure there I have listed where we detach the Achilles tendon from the heel bone, excise the spur, smooth everything down, and then reattach the Achilles tendon with anchors. Other times the Achilles tendinitis can be further above the heel bone, and we can debride it if it's significantly thickened, not responding to those conservative treatments, or we can even inject platelet-rich plasma in those areas to help as well. Ankle sprains are the most common sports injury that we see. There's 23,000 per day in the US that happen. Most commonly, these are inversion sprains like you see from this picture on the right, where we see the ankle roll to the inside with the pressure on the outside. The two ligaments that are most commonly affected are the anterior talofibular ligament and the calcaneofibular ligament, which you can see have small tears in them on that right-hand picture. We treat them by severity, graded 1, 2, and 3, meaning stretched ligaments versus torn ligaments versus ruptured ligaments. And I always tell patients that, years ago we walked these off. We were, this wasn't something that was treated so aggressively and so conservatively. But now we know we need to take care of these because they have a very, very high rate of re-injury in the first 3 months. And so I always tell my patients that it's so important to not only reduce the pain and inflammation, but also get the ankle strong. So physical therapy is a really, really important component to treating an ankle sprain the whole way through. Sometimes patients come in and they're so tender that the first couple of weeks we just keep them in a boot, completely shut the foot and the ankle down, and then we can progress in a few weeks to a brace. When we have frequent ankle sprains, or patients will come in and say, my ankles are weak, or the ankle gives out, or it rolls easily, this is usually a sign of instability. And it's often the result of a severe ankle sprain or multiple ankle sprains on the same side. It can be associated with ligamentous laxity, diseases like Ehlers-Danlos as well. But more oftenly, we're seeing this with patients that have had frequent ankle sprains, and many of them. Like I said before, it has a correlation with that cavus foot type, that high arch that wants to kind of lean over to the side. The difficulty here is that while you might say, hey, I just walk these sprains off, no big deal, I wear a brace for a little bit, over time, that ankle joint's no longer as stable as it should be. And so we see cartilage injuries. I always describe some of these injuries as like taking a swing on a golf course and taking a divot out of the turf. Oftentimes these rolls of the ankle can create similar injuries to the cartilage. And you can see an example of that in the lateral aspect of the talus here where my mouse is, where the bone is black, but all of a sudden we see that very, very white spot. These are precursors to arthritis and oftentimes lead to severe arthritis, but could otherwise be prevented if we're able to treat these ankle sprains early. Conservatively, bracing and physical therapy, similar to how we treat ankle sprains, but oftentimes if these patients have had multiple sprains and never had treatment, they do go on to needing surgery. And this will include procedures to stabilize those ligaments and often augment them to make them stronger, preventing future sprains. Very, very commonly, we'll perform ankle scopes or ankle arthroscopy. We'll remove inflamed tissue in the joint, and we'll also treat those cartilage injuries, those divots that we talked about as well, to prevent the progression of arthritis or slow it down as much as humanly possible. Sometimes, unfortunately, despite injuries, especially severe fractures, we'll have patients that develop arthritis in the ankle. And I always tell patients that we have very, very little wear and tear arthritis in the ankle. Most of it is post-traumatic in nature. And there are some cases of rheumatoid arthritis in the ankle as well. But by and large, the most ankle arthritis we see is due to frequent sprains that were never addressed, or previous fractures where the fracture came through the joint surfaces. Conservatively, we will treat these with injections. We can brace them, and we'll talk about a little bit more about bracing next. And often rocker bottom shoes that we talked about before, where there's some curvature to the sole of the shoe to allow the foot to roll off rather than flexing through the ankle and the midfoot in order to take a step, can be helpful as well. When conservative options fail, we either fuse the ankle joint, or we can even perform a joint replacement in some cases where the ankle is in good position and alignment to do so. This is an example of a molded ankle foot orthosis. This is specifically an Arizona brace. I always describe these to patients as like lacing up an ice skate or a figure skate in your shoe. They fully immobilize the ankle joints, so it kind of simulates a fusion, if you will, but holds the foot at a 90-degree angle to the leg. But what's important about it is that by controlling that motion, we're able to let you wear a normal shoe, but hopefully reducing the motion significantly reduces your pain and allows you to have greater function over time. Here are some examples of different ankle joint implants. I talk to patients all the time that are either unaware that you could replace the ankle joint or don't really know anyone that has had their ankle joint replaced. But these can be great options to maintain motion and reduce pain for patients. And then examples of some ankle joint fusions as well, looking at a plate and screw construct on the left versus an intermedullary rod or nail on the right. In the case on the right, we also fuse the joint below the ankle, the subtalar joint as well for arthritis there. But these can be options for some patients as well to reduce that painful motion if not alleviated by conservative treatment. And that's all I have for you tonight. I really want to thank you all for coming out and for joining the talk. It's been a pleasure speaking to you, and I'm anxious to answer any questions you might have. This is my family here on the left at the Philly Stadium, and then my last trip out to Montana.
Thank you, Dr. Hollinger. We had several questions come through, so I'm going to start reading them off to you.
Very good.
What can I do about tingling in my feet when walking or standing, but never when I'm sitting or lying down?
So tingling in the feet is usually nerve-related, neurological in nature. This can be due to an impingement in a nerve, either in the leg or the ankle or the foot, or sometimes it can even be due to a pinched nerve in your back. So oftentimes, the best way to take a look at this is to have an exam. Sometimes we need to order a study called an EMG or a nerve conduction study to take a look at where that signal that's coming all the way down from your brain to your foot, the area of the tingling and numbness is getting bottlenecked or pinched, and that's how we proceed with the diagnosis. But there's some areas that are kind of notorious for having impingement in nerves, but it sounds like this could be something like a Morton's neuroma, like we talked about earlier, or could be an impinged nerve somewhere else along the track.
This next question has several components to it,
Okay.
but looks like they need some relief from severe peripheral neuropathy. They
Okay.
are questioning if orthotics would help their pain. They believe that this is a result from chemo treatments that they've had in the past.
Sure.
And currently take gabapentin.
Right. So we see neuropathy from multiple causes and sources. Chemotherapy treatment can certainly be one of those, and I've seen plenty of that before. By and large, the most peripheral neuropathy we see is with diabetic neuropathy, but it doesn't really matter where it's coming from. Tingling and numbness in your feet is a problem because it creates issues with balance. It creates issues because you're on your feet every day. And so it can be a major concern in terms of a skin breakdown. So you might step on something, not feel it, not notice it. You might have something stuck in your shoe and it can create an ulceration or a cut or something that can become infected. And then you might not notice it because you don't sense the pain there. So from a standpoint of orthotic inserts, they don't always significantly reduce your pain, but they will allow you to prevent having those ulcerations occur by having something molded to your foot, usually soft in nature, that's very protective for your foot and for your skin. I always try to get my patients with neuropathy into some type of accommodative insert just to ensure first and foremost that we don't have, don't create any skin breakdown. The second part of your question, how do we treat it further? So gabapentin is one of the medications that's indicated. There are a few more that are FDA indicated specifically for diabetic neuropathy, but are known to treat peripheral neuropathy in general. Medications like Lyrica and Cymbalta or duloxetine. Sometimes it takes, tinkering with different formulations and frequencies and doses to get the right cocktail specifically for you. And sometimes we have to look at other sources that could possibly be multifactorial in creating that nerve pain as well. So there's not one simple answer, but oftentimes we're able to get patients comfortable with one treatment or another.
Thank you. This person states so many different opinions. Is it, if safe, preferable to walk barefoot or not?
Yeah, I get that a lot. And, I especially learned early on in practice that, especially the baby boomer generation, they don't like to wear shoes very often. And so we have to, I always have to concede to that sometimes. In general, we prefer people to have good supportive shoes on. Not everyone needs an orthotic insert, but at the same time, just from a standpoint of protection, shoes are really important. We see lots of these types of injuries. We'll even see burns on the bottom of the feet in the summertime when people are barefoot more, stepping on things. I'm removing glass from someone's foot, even in the middle of the winter here on Monday. So these things happen a lot. So just from a sheer point of injury, it's better to have something protecting your feet. With the barefoot running craze, or the minimalist running craze that went on several years ago, we also saw a big increase in those stress fractures that we talked about before. So without that support and doing any significant amount of walking without shoes is quite kind of dangerous from a standpoint of developing one of those stress fractures, just because the foot's craving more support.
Thank you. I have plantar plate along with plantar fasciitis. I don't know if that was the first part I stated right, but is this something that the doctor treats?
Yeah, absolutely. So actually, going back to the hammer toe slide, that hammer toe that I showed you there was actually in combination with a bad plantar plate injury. So we think about the plantar plate as a very key component to the position and the alignment, especially at the base of the toe, where the toe meets the foot. And so oftentimes if the toe begins drifting left or right or up, especially, we have reason to believe that the plantar plate's either torn or ruptured. And that's definitely something that we treat.
Okay. Good segue. We have a few hammer toe questions here.
Okay, great.
Had hammer toe surgery with rods previously done at Rothman that was removed about a year ago, but my toes still curl under. Any exercises that I can do to straighten them? The toes will straighten with force. Okay.
Yeah. So sometimes, we'll do procedures, especially, if a pin was used, it's probably likely that a bony procedure was performed. And sometimes the tendons and ligaments surrounding the adjacent joints will tighten up or contract. That could be due to foot type. It could be due to the way you walk or the way you stand. But sometimes we can do more minimally invasive procedures just to release those contracted tendons and ligaments, kind of what I was talking about, that flexible versus rigid. It's difficult to, do exercises to specifically straighten out the toes. There are some of those conservative like crest pads and things like that will help to alleviate that contracture that you could try, but it's difficult to recommend like a toe straightener or something like that.
It looks like two different people are looking for some clarification of when hammer toes would need surgery versus relying on conservative treatments.
Sure.
To also add on to that, if they delay hammer toe surgery, does this increase your risk of damaging the toe or foot in general?
Sure. Yeah. So in terms of when surgery is necessary, for me, this is purely a quality of life question. So how much is it bothering you on a day-to-day basis? Are you able to use one of those pads or caps or changes in your shoes to get you comfortable? If the answer is yes, and you're able to, basically modify those things that you wear on your shoes or you wear on your feet to fully alleviate your pain, then surgeries, shouldn't be the next step. But certainly if you feel like you've done all you could, you've tried different shoes, you've tried wide sizes or extra depth toe boxes, things like that, and you're still having pain on a regular basis, then absolutely, I think that surgery should be the next discussion. From what was the second part of the question? I'm sorry, Leslie.
If they delayed surgery, are they causing any?
Right. Yeah. So Delaying surgery can certainly lead to further progression of the deformity. So you might see the toe begin to curl more. You might see what we talked about before, that plantar plate injury, where the toe begins to drift left, right, or up. And so, yeah, there could be more damage to be done, and could be a case where perhaps if it was intervened upon sooner, it would be a little bit more simple, or perhaps require less procedures to straighten the toe out. But again, I think this should be something where it's purely pain and quality of life based as to when the right time is.
Thank you. How do you heal bursitis? What type of shoes should be worn? Should I use heat with this? Will that help?
Yeah, so heat can always be helpful. We think about ice in the first 24 to 48 hours after an injury, and heat, moving forward. Bursitis is often alleviated with anti-inflammatory medications, and if we have a cause, or we have imaging to definitely indicate bursitis, sometimes an injection can be performed. From a standpoint of what you can wear, sometimes orthotics can be helpful in these cases, especially if the bursitis is within the forefoot, just to try to reduce those forefoot pressures on the bottom of the foot. And then a good rigid stiff-soled shoe. So I always tell patients, take a sneaker in the shoe store, or whatever type of shoe you want to wear, go ahead and bend it in the middle. You really shouldn't see much of any bend in the middle of the shoe. It's okay if it bends a little bit up at the toes. It's normal to bend your toes as you walk, but a more rigid shoe would be helpful as well, just to reduce the motion there that's exacerbating that bursitis.
Thank you. Sorry, I'm filtering through questions. I'm getting a lot of the same things over here. Will shock wave therapy help my Morton's neuroma, or PT ultrasound?
Yeah, so I haven't personally used shockwave for Morton's neuroma in the past. There certainly are some radio ablation procedures that have come out for Morton's neuroma. That's not something I'm particularly familiar with. My training has been purely surgical for neuromas from a surgical standpoint, and then otherwise conservatively treating with offloading and injections. So yeah, I can't really say I have any experience using shockwave there. Certainly for plantar fasciitis, shockwave has a definite place. And my preference has been to utilize that on patients that don't show evidence of any tearing, but that might have significant thickening.
This person says, I have fibromyalgia and some arthritis in my knee. I have a lot of foot pain and my ankles are very swollen. Could there be arthritis in my ankles and feet as well and be inflamed?
Absolutely. Yeah, that's absolutely possible. I've seen quite a few patients with fibromyalgia. Sometimes that can be a difficult physical exam, just because there's oftentimes with fibromyalgia that no matter where, a firm touch is applied, it elicits pain. But oftentimes I find that we can isolate the pain, and especially with X-ray, can look for things like arthritis and other issues that might be causing the pain aside from the fibromyalgia. So absolutely, there could be arthritis there.
It seems the Hallux limitus is closest to the pain I deal with. Certainly overuse and probably arthritis have contributed to my problem. I throw collegiate batting practice at an excessive rate, 200 to 800 pitches, 3 to 4 times a week. I would love to see what can be done so that I can walk for exercise again.
Sure, absolutely. The procedures that we do from a surgical perspective for Hallux, limitus, and rigidus, they're purely based on the severity of the arthritis and the amount of joint destruction that may or may not have occurred. There's times when surgery is not warranted, and we can do some of those conservative things, stiff-soled shoes, orthotics, injections, things like that, that can considerably alleviate that pain. But there's definitely joint sparing procedures and also the fusion procedure that works works really well. Some of my most happy patients have been great toe joint fusions. That, you know, sometimes that word fusion is kind of like a dirty word. No one wants to talk about taking away motion, but oftentimes people say, oh, wow, I wish I would have done this sooner. I really can push off just fine. I'm walking fine. I'm doing the things I want to do without pain. So it really just depends on where things have progressed to at this point, but we can absolutely help you.
Still some more coming in about shockwave. Is that considered experimental treatment since insurances do not cover it? And then also, what do you think of TENS treatments for plantar fasciitis?
Yeah, so TENS is definitely something more in the physical therapy world. So some of the physical therapists, you know, use that modality more than another. I don't typically prescribe TENS units for plantar fasciitis. It certainly can be an adjunct in terms of treatment, but it's not something that I rely upon, you know, solely to get patients better. I do think it can only help in those situations, though. From a shockwave perspective, yeah, you know, there was an article that came out years ago, actually in the Australian literature, that showed it was kind of equivocal. They couldn't say yes or no. I find that in my practice, shockwave is something that I can offer to patients that are very hesitant about surgical procedures and even minimally invasive procedures. So someone that would like to try, you know, a modality that does not require any incisions whatsoever. Usually it does require an injection just to block the nerve above the ankle to make sure that the heel is numb for the treatment. But yeah, it's another option that doesn't require surgery or any kind of invasive treatment.
What causes benign cysts in toe joint, in the big toe joint?
Yeah, so we see cysts, we refer to them as ganglion cysts or mucoid cysts that are commonly occurring from the joints themselves. So they can either come off of a joint capsule, a tendon sheath, or a nerve sheath. They're fluid filled from the fluids that lubricate those structures. I think of them as kind of like attaching a straw to the joint and having a balloon on the other end. Sometimes, you know, they can be drained and that's the end of it. And that's something we can do in the office. And other times, you know, they have a very, very high rate of recurrence. And the only way to fully alleviate them is to surgically excise them. And sometimes that also includes doing surgery on the joint too, to make sure that we're getting the root of the matter there. Other cysts that you might be referring to can be within the bone as well, and that is kind of just dependent on the situation. We see cysts that occur around the joint from arthritis and things like that as well. But it sounds like you're probably talking about a mucoid cyst or a ganglion cyst.
This person says, I have to wear shoes to sleep at night, or I wake up with nerve pain in my middle toes. Any suggestions to avoid pain other than going to sleep with my shoes on?
Yeah. You know, it's interesting. I've heard a lot of different patients, especially with neuropathy or neurological pain, that it's purely positional for them. Some patients just absolutely cannot tolerate a lace-up shoe or like a fully closed shoe. They have to wear something open-toed. It sounds like for you, it's the exact opposite, that your foot kind of craves that surrounding support. You know, like we talked about in one of the earlier questions, there are some medications available to treat peripheral neuropathy, and you know, certainly diagnosing the root cause of the neuropathy would be helpful as well. So why the neuropathy may or may not started in the first place is definitely the key component to treating this.
I'm going to read off 2 questions and then we will wrap up here. Can you explain recovery from Achilles tendinitis? Yeah,
so you know, oftentimes when I diagnose Achilles tendinitis, we start with stretching exercises, anti-inflammatory medications, and a course of physical therapy. The goal is to really stretch out the calf muscle and the Achilles tendon to reduce the strain there. Recovery can be anywhere from 6 to 12 weeks in an acute case. There are many patients that have had a form of Achilles tendinitis for years, and those cases are much more difficult because oftentimes that tendinitis often turns into what we call tendinosis, and that's actually a change in the collagen fibers in the tendon. We see thickened areas of the tendon. And in those cases, I'll actually prescribe a form of therapy called Graston or ART to break up scarring, adhesions, and to increase blood flow to those areas from a conservative perspective. But yeah, that timeline for acute Achilles tendinitis is usually a minimum of 6 weeks to recover conservatively.
I'm sorry. So again, back to heel bursitis. What type of shoe would you recommend? Does heat help with that? And when we talk about RX, is there any sort of natural medications that you prescribe outside of taking a prescription?
Yeah. So there are the shoe that we prefer for, for most things that, pains in the foot and ankle is going to be more rigid. So like I said before, kind of taking that shoe or sneaker in the store and, bending that, making sure you can't bend it in half. You can't, twist it in your hands. You can't tie it in a knot. It's amazing the poor quality of shoes that are out there these days. So you really have to be careful. There's not one brand to recommend. It's simply taking that shoe in your hands and making sure that it's rigid and stiff, and it's going to provide you good support. Inserts can be helpful as well to support the arch. Heat for sure is helpful. I oftentimes try to avoid ice with plantar fasciitis, or it sounds like that might be what you're talking about with heel bursitis, especially because the whole goal of treatment is to try to stretch out the plantar fascial ligament and the Achilles tendon. And, if you think about it, you put something cold on there, it's going to naturally contract, just like metal contracts, when it's cold in the wintertime. And so I prefer heat in those scenarios. There's a number of kind of homeopathic and natural remedies in terms of supplements and things like that. Patients often come to me utilizing a number of different things, but yeah, medicine's not always the name of the game with heel pain. It can be helpful, but not always necessary.
Great. Dr. Hollinger, thank you so much. I just want to remind everyone that tonight's lecture was recorded and you will be receiving a copy of it via the same email that you used to register for tonight's event. If you're interested in learning more about Dr. Hollinger or scheduling an appointment with Dr. Hollinger or another physician here at Rothman, you can do so by visiting our website, which is rothmanortho.com. Right up at the top, there is a button to click to make an appointment that will give you all of the different options for doing so, whether that's there on the computer or giving us a call. But thank you everyone again for joining us, for taking time out of your evening. And thank you, Dr. Hollinger, for educating all of us.
Thanks so much for the time. Really appreciate all of you joining us. And I hope this was helpful for you.